Hi, again I am so glad to meet you in this program 3 Point Medics 3 p.m. program. So in fact we have been learning about prothrombin. So yesterday we saw 3 important causes of increased prothrombin, namely liver disease, vitamin K deficiency and antiphospholipid antibody syndrome. Now we are going to see 2 more important causes. Point number 1, the 2 more important causes is 1, disseminated intravascular coagulation, and second one, inherited deficiency of clotting factors. Number 2, what is disseminated intravascular coagulation or otherwise called DIC? The name itself implies that disseminated, that means throughout the body there is an coagulation cascade inside the intravascular system. So in fact DIC is characterized by excessive consumption of coagulation factor which result in thrombi formation in all kind of small and large vessels throughout the body, resulting in vascular occlusion leading to gangrene of all the vital organs. Since there is excessive consumption of this coagulation factor, at some point of time there won't be any adequate coagulation factor in our body for day-to-day coagulation. So what happened? Because of this substrate deficiency, because of deficiency of coagulation factors due to excessive consumption in DIC leading to bleeding. So one end there will be formation of thrombus which occludes the blood vessels, and another entity where because of extensive thrombi formation leading to coagulation factor deficiency resulting in bleeding. So normally DIC is seen in 2 important conditions, one is sepsis and second one is any kind of severe trauma. In both these conditions all the coagulation cascade is activated resulting in DIC. Apart from that, DIC is commonly seen in any malignancy, even obstetric condition like abruptio placenta, even in lymphoproliferative disorder, acute pancreatitis or so on. There are so many conditions that can lead to DIC. That's why in most of the tertiary care hospital, PT-INR and APTT are part of their routine test. So generally any patient who presents with thrombocytopenia, especially somebody presents with fever and tachypnea, suspecting sepsis, you are doing procalcitonin which has got elevated and you find leukocytosis or leukopenia and thrombocytopenia. When you find thrombocytopenia, don't be content with thrombocytopenia alone. Please suspect DIC in these patients. So you proceed with prothrombin and APTT. If prothrombin is elevated, thrombocytopenia is there and a decreased fibrinogen level, increased fibrin degradation products all may contribute toward the diagnosis of DIC. Why we are specifically go in search of the diagnosis of DIC in the presence of thrombocytopenia? Because DIC in any condition carries high mortality, whether it is sepsis or whatever the reason, DIC always highlights the high mortality with particular disease. That's why if any patient is found with thrombocytopenia, better to go for detailed evaluation. So there is a specific scoring system in which if the score is more than 5, we always suspect DIC. So the parameters include platelet, PT, APTT, fibrin degradation product and serum fibrinogen and so on. Point number 3, I told apart from DIC, one more cause, inherited deficiency of coagulation factors. We seldom encounter this inherited deficiency of coagulation factor. So anybody can have inherited deficiency of all kind of one of the coagulation factors, but we commonly come across is 8 factor deficiency or otherwise called hemophilia. So since factor 8 involved in extrinsic pathway which is always highlighting activated partial thromboplastin time, or otherwise called APTT. So when you have 8th factor deficiency hemophilia, APTT may be prolonged, but most of the time prothrombin time will be normal, because for prothrombin formation this 8th factor doesn't take part. So in the presence of congenital 8th factor deficiency, most of the time prothrombin time will be normal and APTT will be prolonged, and they will have normal platelet also. So when you find some isolated APTT prolongation in the child group with the tendency to bleed into the joint or mucosal bleeding, suspect 8th factor deficiency. In that case, do PT prothrombin time, that will be normal, because in prothrombin formation 8th factor doesn't play a major role. On the other hand, APTT will be prolonged and platelet will be normal. With this, I would like to end it. So tomorrow, what would be the interference factors for prolonged prothrombin time? I mean, without any disease, there may be few conditions where you will have increased prothrombin time, and there may be a very rare case of shortened prothrombin time as well. Tomorrow we will see. Thank you.